Well, one of the things I've tried to do in my profession is to surround myself with people who are smarter than I am. So, Jason, thank you for making that possible today. And so, for all of you that are here, I'll be leaving Friday at 3 o'clock, so if you can meet me in the lobby, we'll all be going to Louisville. Now, listen, I want to tell you a little bit about what we're doing in Louisville. You know, we are the home of the Kentucky Derby. Some very exciting things are happening there. We're bordered on the north by the Ohio River, and the community is surrounded with a link of parks. There are Frederick Law Olmsted designed parks with beautiful parkways leading to them. There's the Shawnee Park to the west. There's the Iroquois to the south, the Seneca and Cherokee to the east. It's beautiful neighborhoods. It's like living in an urban forest, you know, great canopies, wonderful understory trees, the dogwoods and the redbuds. Great place, beautiful. We're also flooded with substance abuse problems, and primarily heroin in our community. Let's see if I can move this forward. All right, so here's what we've got. We run a jail. We're a large jail. And that means we've got over 2,000 people in custody every day. On a daily basis, the police are bringing about 100 customers in, and on a daily basis, about 100 people are leaving. But still, on top of that, there are 2,000 individuals in custody. So let me just tell you a little bit about what goes on there. Last year, there were 32,000 people booked into custody. 32,000, that's a pretty good-sized city. You know, the jail is a temporary holding facility. It's not a long-term, not designed for long-term. So people are there for a couple of hours, a couple of days, a couple of weeks, a couple of months, sometimes a couple of years. But what happens is that the police bring them to us in whatever condition they find them on the street. So we've got people coming to us with more serious health care needs, more chronic conditions. They're not taking care of their diabetes, not taking care of hypertension, and they're impacted by substance abuse. So if you look nationally, and we fit in with the model, about 85% of the individuals that get arrested their lives are impacted by substance abuse. That doesn't mean that's the charge that's brought against them that landed them in jail, but their lives are impacted. The other thing is that we've got a daily population where we know, and again, pretty consistent with the national figures, that 25% of the men and women that are in our custody suffer from a mental health condition. It's a diagnosed condition in which they are receiving treatment for. They may not be compliant on the street, but they've been receiving treatment for it. And there's another 25% that have not been diagnosed that have a serious mental health problem. So that's the kind of the look of the jail population, and it's driving health care needs. So this is the only population, the only group, a protected class in America that has a constitutional right to health care. That's inmates. And we are working hard as a department to take care of the needs of individuals when they come to us, and taking the next step and trying to take care and address the needs of individuals as they leave us. So, you know, here's what we're doing. We have been looking at the number of individuals that come to us that are suffering from an ongoing chronic condition of substance abuse. And we've been tracking these individuals for a number of years now. And what we're doing is we are running these individuals through a detox process inside the facility. It's primarily a cold turkey detox process. So we're dealing with those symptoms. You know, for those you don't know, the symptoms of detox from opiates and heroin, and that's the primary drivers you can see, is that you're just sick. You have flu-like symptoms, you can't control, you know, you don't want anything to eat, you want something to eat, you don't want the lights on, you want the lights on, you need to get to the shower to get cleaned up, get your clothing changed. It's just much like a flu. So, you know, what we've done is we have begun to address this in a very progressive way, and that is we used to just take everybody that came into our facility and we looked at them and we said, here's your classification. We're going to make your classification based on what your crime is. So we have a minimum, medium, and maximum classification. And then what we would do is we would flood all those individuals into those classification housing units, whether they were sick or not. They were all going into these various units, and then getting inside, they were experiencing their symptoms. The other cohabitants there were upset with that, wanted them out, and we were taking them out and putting them in smaller, more confined spaces and leaving them 23 hours a day. You know, checking on them, but that's where they lived. They didn't come out, except for 1 hour. And we had some tragedies as a result of that. So we've changed that model. Now we funnel everyone into a housing unit where we have the training, the expertise to manage these symptoms that are being exhibited by the individuals that have either an addiction to a substance abuse that is benzodiazepine, opiates, or alcohol. Tremendous change. And so we've got, you know, you're talking about a correctional setting, not a healthcare setting, right? So we had some resistance on the front end to even do this by security staff, you know, because what we were doing is providing things that were different for individuals in these particular dorms than the rest of the population, like, you know, something as simple as Gatorade, something simple as a change of clothing, something as simple as clean linens inside the housing units, a clock on the wall. You know, a tremendous amount of resistance at the beginning of that. So, you know, we look at our population again, and we've got, last year, we had about 7,500 individuals that came through the facility that went through our detox protocol. Every day, between 60 and 80 people are in a dorm under observation on a detox protocol every day, no day off. And then what happens is we don't get to control when people come or go. So individuals are leaving our facility the second day, the third day, the fourth day, and really that's in the middle of detox. You know, it takes 5 to 10 days really to get through that detox, get through those symptoms, and get stabilized again. And so when they're leaving before this is completed, guess what? Yeah, they just want to feel better. It's not like we're going to go out and get high again. They just want to feel better. They want the symptoms to go away. We would all do the same thing. If we could get a shot to get rid of our flu symptoms, we'd take it. And if the flu symptoms came back a couple of days later, we'd get another one. So we see this happening, and we decided to do something about it. You know, we were doing really nothing about it for these individuals leaving our jail. We weren't going to do nothing anymore. We decided to do something. So we engaged in a evaluation of this, of our concept, and our concept was to try to find ways to get individuals into a path, leaving our facility, into a path. There was no cost to them. It would be direct. We'd drive them to a location, and we did a feasibility study to see, well, how are we going to pay for this? And what's it going to do? And how's it going to save us anything? So what we wanted to do was save the return to these individuals coming back. You know, all right, so it's a little selfish. We didn't want them back. So we wanted to save that. We wanted to prevent them from coming back to us because, you know what, they're the high consumers in our facility. You know, they're on the second floor where the medical staff is, where the psychiatric unit is. You know, it's services, high consumers of it. So, you know, we know what the cost is. There are 2, sometimes 3 times the cost that it is for an ordinary inmate to reside in corrections. So we began to evaluate that, and we looked at other things we're going to try to measure in order to get some return on this. So what our plan is to take this group of individuals, move them into opportunities as they're leaving the door to continue the path for detox, get connected to treatment, and move themselves to recovery. You know, so not only is it the right thing to do, because, you know, it's going to contribute to our social muscle in our community. It's going to contribute to the value of community. You know, and we're going to see this, we know we're going to see individuals that are going to stop coming back to us, and if they do come back, it's going to be less frequently. And when they come back, they're going to be in less serious condition, because we're also enrolling them in insurance through the Affordable Care Act while they're with us. And then we're going to get them connected with the community. We've already developed great community partners with other programs that we have already. So we know we're going to be successful. So where we are right now with this process, so we did a feasibility study with the help of Harvard Kennedy, and we determined that it was feasible to engage in this, take this risk, and try to help individuals who are leaving the jail. So The current status is that we have narrowed down the service providers in the community that are willing to cooperate and that we're going to choose from and offer the pathway for individuals leaving us. We have an intermediary that's going to help us move the individuals from our facility out into the community. So we're moving along pretty well on this process. So as you can see, we've got a lot more individuals than we can serve that need the assistance. We've got the 2 different types of treatment that we're going to look to pathways for individuals to move into. So we've got the data to track this and look at it and compare it. So we're on our way to a very interesting time, and we think we're going to be very successful. What we don't know is really how to keep track of individuals and how to evaluate the data and really how to structure this whole process. These are just things, there's not a model out there we can look to. So that's one of the things, we're very excited that JPAL is going to help us with and put us on track to achieve success. One of the things we're really looking forward to is some of the early failures in this so that we can find out, what to do better. Looking forward to a long engagement and a successful program. So thank you very much. All right.